Like the more the time you give to obstetrics, I feel like it's always not enough. So if you get the chance and if you have time, please give a lot of time to obstetrics. Believe me, in MCCQE1, if you are the lucky one, you will get so much obstetrics. Like I personally believe like 70 to 75%, there is so many cases of obstetrics, like coming from pediatrics, coming from gynecology, coming from emergency. They do like to ask obstetrics a lot. And if the more you read, the more you feel like there is something that you are missing. So that's why I feel like if you have a study partner or if you don't have study partner, at least find someone to read obstetrics with, because you never know, people have very very nice concepts and you never know, people have not even known anything about obstetrics. So in that case, I would suggest like read it with someone, at least the topic obstetrics, because people do help a lot with making concepts of obstetrics, and there's people who destroy your concepts too. Okay. Then we are starting from the start. Like if you have time, let's suppose 2 weeks before exam, at least give one whole day to obstetrics and read it thoroughly. Even how many times do you do the revision? You can do like little bit from all of the topics, but for obstetrics I would suggest read everything if possible. Everything I will tell you from where you have to start everything. In this one here is like the placenta. What is placenta? It's like a nutrition and the gas exchange between the mother and fetus. Then comes the pregnancy, how you're going to start with the diagnosis. So it's like GT, PAL, and then in that one we go for gravida, para, looking for abortions, and then live, that one. Physical is basically checking for the uterine and abdominal enlargement, breast engorgement. Then there is Goodell sign, Chadwick sign, Hager sign. Just if you can memorize, at least remember that which sign presents which time. So for me, I only memorize that all of these signs should be in 6 week pregnancy. Okay. So then investigation is basically we go for beta HCG, although we go for urine test first and then we go for the blood one. So then you need to know that at what time the blood ones start showing up positive. Okay, that's very, very important. Give me a second. Okay, so here positive in serum at that 9 day post conception. So people can present like, oh, I am missing on, like not missing on, I did like unprotected sex, and I think I am pregnant. I did a urine pregnancy test. Let's suppose they did it like that, and it came out positive. So I want to go for the serum. So in that case, it should be like in 9 day. Or some people do urine pregnancy test or up above their periods, and they want to do serum, and then serum came out negative. In that case, is what you can do is you can ask them to or counsel them. We will repeat the beta HCG maybe in a week just to see, because sometimes it is maybe not the 9 day after the post conception. So just for your idea, it can be asked in the question. So it can be asked like, what could be the cause, or what will you do? So in that case, it is reassurance and doing the beta HCG again. Positive in urine at 28 day after the first day of LMP. So plasma level doubles every 48 in the normal developing pregnancy. So I told you, all the people say that it came out positive in the urine test, but like they don't know how to check it, or something like that. That's why it came out positive for them. And now we are doing in the serum and it came out negative. So it's better to just do the reassurance instead of telling them, oh, you are not pregnant or whatever. So you can tell them, oh, we will repeat this beta HCG again in like 7 days. Plasma levels double every 48 hours in some people, especially in Canada. What we do is, like, I recently been treating a patient who is having vaginal bleeding along with she's pregnant. So in that cases, we are doing all like going for ultrasound and everything is safe. But me as a family physician, what my thing is, and he cannot or she does not want to go to emergency. So in my case, what I can do is basically repeating the beta HCG. So we are repeating her beta HCG. I gave her a paper of every week, not every week, yeah, every week. Every week beta HCG, and we are checking the levels. If it's the level is increasing, it means the pregnancy is going well. But if not, then we have to look for the other options. Is a normally developing infants from the time, so they can ask you in which cases you will do the beta HCG repeating, or how would you like to check if the pregnancy is going well. So in that case, is repeating beta HCG. it levels to 10,000 and then falls down. So you need to know at which time the beta HCG levels are max. So usually at 10 weeks. So less than expected can cause the ectopic pregnancy and all of that. So then ultrasound, whenever you do the ultrasound, this is very, very important, especially here in Canada. Usually by the time you get the first ultrasound, you're already in second trimester. But it can be asked like if you by chance get an eye like an early ultrasound, so which one is that one? So fifth week is the gestational sac visible, sixth week is the pole, and then 6 to 8 week is the basically fetal heart rate. So heart activity, this is important, and then gestational sac like when it's going to start showing up. Okay, so 5 to 8 week the pregnancy will be visible. Then at 8 week it will be like the heart rate is very, very important. Then on the side, be conscious of the language and all that. Discuss with the patient with the termination of pregnancy, and always after talking about the termination or delivery of the baby, don't forget to talk about contraceptives or family planning. Establishing the desirability of the pregnancy in a patients with a suspected or confirmed pregnancy informs the construction of appropriate management plan. Then beta HCG rule of 10. So by 10 week, it's basically 10,000. Then trimester 1 is basically for your ideas. Then what could be the changes in this one? The main important changes is basically thyroid changes. And What more was there? Which one is this? Yeah, this one here. So the most important is where is the endocrinology in this one? Yeah, here. Thyroid in moderate enlargement and increased basal metabolic rate. So increased total thyroxine or thyroxine binding globulin. So in those patients, we do increase the thyroxine level, in dose if they are taking. Normal free thyroxine index and then TSH levels. Then possible suppression of the THC in the T1 is common due to the cross reactivity. Then adrenal is basically increase the cortisol level. Then calcium is basically decrease. So we give calcium in the females. Then the ionized calcium, it could be there and increase with the bone absorption. Then the next thing here you need to do is genitourinary. In that case, is what you need to see is there is an increased urinary frequency and any kind of leukocytes that is present in the urine, especially in pregnant female, you have to treat them regardless of the symptoms. Why? Because the chances of preterm delivery is there because of this one. So it can be asked, what is the complication of asymptomatic leukocytes in the urine? The line will be same exactly like that. What is the complication of the asymptomatic leukocytes or high leukocytes in the urine? Like there is no blood, there is no nitrate, only leukocytes are there and patient is not having symptoms. So in that cases, there are some people who does not want to go for antibiotics. So you have to tell them what are the complications it can cause. Increase the incident of UTI and pyelonephritis could be there. Glycosuria can be established in the T3s, and that's why you have to check for the gestation diabetes in the second trimester. Then ureteric and the pelvic dilation is there, increase CO, and then increase the GFR to decrease the creatinine. If you have time, you can read the other thing, like it can cause constipation. So you have to watch out for that one. In the people who have gallbladder stones, in that cases, we don't do anything, or you can ask them to after the pregnancy, usually it can be treated. Then the respiration in that one, the oxygen supply is consumed more. So you have to like tell them to not lie flat, turn on the side if they are having any of the hypoxemia. Otherwise, cardiovascular, there is basically mainly chances of hypotension. Skin, there is like all those like linea nigra, spider angiomas, palmar edema, all of that one is there. And in the female, the most important is the carpal tunnel syndrome. Although sciatica, Bell's palsy is there, but the carpal tunnel syndrome is one of the very common presentation. Then comes the preconceptal counseling. This one is very, very important and can be asked in many, many, many questions. Okay. And each and every single line is important. 3 to 8 week is the critical period of organogenesis. So you have to tell them you have to be very, very careful, especially with the females. They ask about Tylenol use. Oh, if I'm having fever and all that. So you can tell them you can use Tylenol and avoid antibiotics if they are not needed, and then tell them use it only when they are having very high fever or very high pain. Then past medical history, optimize the medical conditions and any other condition like hypertension, gestational or anything. Diabetes. Then always start folic acid. Here we start with Ferramax or the Materna, whatever the folic acids are there. Then comes the prenatal vitamins. We already know which ones are those ones in T2 and T3. So usually people only go for T1s, but if there is blood work you have done and there is iron deficiency, you can always tell them to do T2 and 3 in second and third trimester as well. Increase the social risk, check for smoking, alcohol, substance use. You always encourage them to stop, but you cannot force them to stop. Same goes for a substance use. You can tell them to stop, but you cannot force them. Domestic violence, occupational, then poor social, and then nutrition and physical fitness. Medication is that discuss teratogenic medications. As I said, if someone is very like, oh, I'm having sore throat, I want amoxicillin. You told them consequences of amoxicillin. She still wanted it. Then in those cases, you have to tell them, and then you can actually prescribe it to them. Then the infectious screening is basically we check for rubella. Usually we go for everything. MMRV like measles, mumps, rubella, hepatitis B. We go for HIV. We go for what else? Syphilis. We go for like people go for HSV as well, but HSV does not make any sense or anything to do. Then there is prenatal screening, whatever it is there. So chlamydia, gonorrhea could be tested as well. Uh, People don't go for TB testing unless until you feel like, oh, it's refugee or indigenous, and those cases, TB is very, very common. History of varicella and vaccinations, parvovirus immunity to be a small vaccine because they don't know about vaccines. So that's why we do go for all the testing and checking for immunization record. In that way, we can find out if they are short of any vaccine. So after pregnancy, they can be given. Genetic testing as appropriate for the high risk groups and consider the genetic referral in known carriers like recurrent pregnancy loss, family members, then developmental delay, birth anomalies, then genetic disease and consanguinity. Then on the side, you can see what are the considered obstetric consultation for where you need to be seen by obstetrics right away. Usually, a family doctor can follow with the like a pregnant female, but in some cases, like having gestation diabetes, HTN, multiple gestation, preterm labor chances, IUGI, in those cases, you have to be seen by obstetrics right away. Advise all the patients capable of becoming pregnant to supplement their diet with folic acid. Okay. Then the initial prenatal visits, how do you do it? So you can just give it and read about what to do is this one. Then gestation by week from the first day of LMP. What is the dating ultrasound? That is one of the most important question. Okay. When is the dating ultrasound to be done? Usually, as I told you, it's the first appointment you get is by the time you are already at 16 week or 18 week. But if someone is lucky enough to get something early, so in that case, it's basically 8 to 12 week. And if they have done, it's basically tell you what is the exactly dating going on. Ultrasound after 7 week, more reliable than LMP if difference is greater than 5 days from LMP due to the date. Then checking for other things. In history of previous pregnancies, always ask about gestational, termination, para, and abortion. Then comes the year of the delivery, fetal sex, weight, age, mode of delivery, and length of labors and complication. Then physical examination, checking for all the investigations we already checked, and then pap smear could be there. Establish date of the delivery determined by LMP if mens is regular, patient's reliable historian. I'm not sure. Recently, there is so many patients that coming to the clinic and asking about HPV. Is there any HPV screening in Canada? It's just I was talking about HIV, so it came to my mind. So just to let you know, in males, there is no HPV screening. Okay. Usually they do get the vaccines by in their school, like in 12th grade or whatever it is, or 12 years. So in that time, they do get their vaccines. But if they didn't get a vaccine or they do have HPV or don't have HPV, you cannot do any screening for that. Or I did not see any screening for that. In females, the pap test is the one that helps with the HPV or whatever screening. But in males, there isn't anything. So like I recently saw a male person who came and then he's like, my partner, she recently did a pap and then HPV came out positive. And but she told me that she got the HPV from him. So I told him that it's not you, it was maybe there in her blood or whatever, and now it's showing up. So, or in your case, we cannot do any screening for you. All I can do is I can give you a booster dose if you want. So in that cases, you can just offer them a booster dose. But if they're sexually active, in those cases, even the booster dose or HPV screening does not work. Just to let you know. Estimated date of delivery determination by LMP if MENS is regular patient reliable historian, then by T1 ultrasound, the most accurate dating ultrasound is basically by establishing if embryo age and the date of transfer, if IVF, and then changes of the EDD must be documented and discussed. Patient pregnancy without ultrasound confirming or advised CDD prior to 22 is considered suboptimally dated. Then comes the nausea, vomiting. In that cases, the main important is checking for their dehydration status. So I think from here on, you have to read everything. Okay. Then the rule out other causes of nausea, vomiting, especially if they're refractory to initial therapy. Then check for the weight, level of hydration, their drowsiness. Then test the urine for ketones. Not pharmacological in you have to give the small meals. Encourage any safe appealing food, electrolytes, which electrolytes Pedialyte and Gatorade. Then stop the prenatal vitamins because folic acid can cause a lot of vomiting. So then increase sleep, ginger, acupuncture, acupressure, and then mindfulness. I would rather go for no ginger because you never know, people start eating too much of them. Then comes the pharmacological. First line is pyridoxine. Simple. If they ask you which is the first line, pyridoxine is the one. Monotherapy, or you can go for ditherapy, which is basically dialectin. Then the combination of 4 tablets per oral daily up to maximum of 8 tablets. So you can tell them how much they can take maximum of the 8 tablets. Then H histamine receptor antagonist could be used for acute or severe cases. Then the metoclopramide, phenothiazine. So mainly we go for pyridoxine. Then there is metoclopramide like gravel and all that. Ondansetron can be given if severe nausea, vomiting, and in many patients, usually doctors find it safe to go for ondansetron before starting anything else. I'm not sure why, but they says in pregnancy the ondansetron has less side effects as compared to other. Just for your knowledge. Then consider use of acid reducing mechanism as the adjunctive therapy, then antacid H2 blockers and PPIs. Then hyperemesis gravidarum, it's getting crazy, usually present in the T1. Rule out the systemic causes, rule out obstetrical causes if there's a multiple gestation. One of the most common cause of hyperemesis gravidarum is multiple gestation. So think of that one. Then in that case, we have to start with thiamine, then non-pharmacological, and then pharmacological. In that one, IV fluid, and usually we put the pyridoxine in the normal saline and then give them that slowly. Diphenhydramine can be used such as adjuvant to the dialectin. Then others are the hydroxine, pyridoxine, or densitron, or the methylprednisolone. If severe, admit to the patient, then NPO initially, and then slowly start that one. And then in that cases, you have to think of the refeeding syndrome could be there in this one too. And what are the complications? Hydration, dehydration, Mallory-Weiss tears, Wernicke encephalopathy, and then death. Now you can see subsequent prenatal visits. What do you do slowly? Then what is the Lippert maneuver and all that. Then symphysis fundal height is 12 to 12 weeks. So I just remember up to umbilicus is 20. So if the symphysis height is below umbilicus, then it means it's less than 20. If it's above, then it's more than 20. Simply, I just kept this thing in my mind. With umbilicus is 20. Then what could be the symphysis fundal height less than date? In that case, is maybe the date is miscalculated, IUGR, baby died, or that oligohydramnios, early develop engagement, or the transverse lie. In the below one, there could be the date complications, multiple gestation, polyhydramnios, and then large for gestation and fibroids. So just to let you know that in our normal visit of a pregnant female, if you are working as a family physician, you are checking symphysis fundal height, just for your knowledge. Prenatal screening and diagnostic test. In this one, high risk population screening test, thalassemia, sickle cell, cystic fibrosis, stay second, then fragile, or these ones. This one is the most important table for screening investigations. So pre-implantation, what are the screening? All require IVF, so you have to do all kind of testing. Hemoglobin electrophoresis 2. Okay, so we do everything. Then 8 to 12, in that case is dating ultrasound, pap smear, chlamydia, gonorrhea testing. So you can do pap smear, okay, if she is due for pap. Then urine culture and sensitivity, HIV, HDRL, but you have to tell the complications of pap smear too. Hepatitis B, rubella. So we are going for everything, as I told you, MMRV, checking for parvovirus, if there is any, then varicella, CBC, and all that. In more than 10, we go for NIPT, which is we check for the maternal circulation. In 10 to 12, we go for CVS, which is invasive procedure. It is a diagnostic test. It is not a screening test. So just to let you know, there is two diagnostic tests. One is at 10 to 12. The other is at 15 to 16. There are two diagnostic tests. So they can be asked, a patient presented with a 18-week pregnant. So now she is thinking that she had something, and then she had a previous history of a baby with Down syndrome, and now she wants to go for diagnostic test, right? So now she's at 18 week. You cannot go for CVS. You have to go for amniocentesis. It is a straightforward question asking you if you could tell which diagnostic test could be done at which week. Simple and straightforward. So you have to keep it in your mind that for the CVS, it has to be done in 10 to 12 weeks, like chronic villus sampling. And then the amniocentesis has to be done into 15 and 16. Most important thing, these both are diagnostic tests, not the screening test. So if a female is coming and she did not have a previous history of the Down syndrome and she's thinking, in that cases, you have to go for screening first, not for diagnostic. Okay. But if she has a previous history, you have getting more of the thing that you feel like she could have like the Down syndrome. So in that case, it's going for Down syndrome because, sorry, diagnostic test. Diagnostic test is more invasive. Sorry. Diagnostic tests are more invasive and it can cause the miscarriage. Then in 11 to 14, EFTS or IPS1. Then 11 to 14 is the knuckle translucency. Okay. So just for your idea, you need to know the 10-week and 12-week one. Which one is that one? NIPT, CVS. 11 to 14 is knuckle translucency ultrasound, checking for if there is anything happening going on. So in that one, we go for Meyer, the knuckle translucency, beta HCG, PAPP, and then placental growth factor, MSAP. Then 15 to 16, we go for amniocentesis. In 15 to 20s, we go for the IPS, which are those ones where you check for the maternal serum alpha fetoprotein, beta HCG, unconjugated estrogen, and inhibin A. Then 15 to 20, you go for maternal serum screening, where you do everything. So usually 15 to 20 or the other one, IP1, whatever, that one, we can skip that one. And in 15 to 20, people usually directly jump to a maternal serum screening. And then 18 to 22 term is basically fetal movements, quickening. So asking from the mother about that. Then 18 to 20 is ultrasound for the fetal size and namely. So 8 was dating scan, 18 to 20 is fetal size and assessment, and then checking for male, female, whatever the thing is. Then 20 to 28 is gestational screening. So please remember this gestational screening. I saw many MCQs in certain groups where they were asking about the gestational diabetes screening. Then 828, repeat CBC, ferritin, then ROGAM, immunoglobulin, you have to give, she is Rh negative. 35 to 37, GBS screening, it's important, and we will see in which cases you have to do the GBS screening. Then the 6-week postpartum, discuss the contraceptive, menses, then breastfeeding, depression, mental health, sport, physical exam, breast exam, then pelvic exam, include the pap smear and wounds assessment, everything. Then coming to the ultrasound screening, we already know at 8 week, it's a dating scan. Then 11 to 14 week, we check for knuckle translucency. And then 18 to 20, we check for the anatomy and then growth. Here is something in the NIPT. There was something, just give me a second. Okay, so NIPT is analyze the maternal circulation for circulating. So in this, the question is, in this one requires the dating ultrasound for accuracy. So if you do NIPT and it shows any abnormal result, it needs a dating ultrasound. And along with that, if there is any problem, earlier timing with results available in 1 to 2 week. So in that cases, you can go for CVS at 10 to 12 week. But if it's more than 15-week amniocentesis, I think I already told you about that part. So if there is any problem in NIPT, first thing is dating ultrasound. Then second, based on which week it is, you have to go for CVS or amniocentesis. Then it does not screen for ONTD or like open tube neural defects and need to confirm by invasive. So if there is any problem in non-invasive prenatal testing, if there is any problem in that one, it is not diagnostic. So you cannot tell the mother that she is having, because there is patient that come with, oh, my NIPT came out abnormal. So do I have Down syndrome? So you have to tell them this is just a screening. It does not indicate that you have Down syndrome, or it can be asked in your questions as well. Then here is maternal serum screening and then IPS. In that ones, you can just read this one. Patient with a positive screen should be offered CVS, amniocentesis, or NIPT. In maternal serum screening, patient with a positive screen should be offered ultrasound, amniocentesis, and NIPT. In IPS, patient with positive screen should be offered ultrasound, amniocentesis, and NIPT. So first thing first, if maternal serum screening, IPS, go for ultrasound. But in FTS, usually we can directly go for CVS and amniocentesis. Okay. So FTS is more reliable as compared to maternal serum screening and IPS. But people usually go for MMN and maternal serum screening. So in that case, you have to offer the ultrasound. Then we already discussed which are the diagnostic tests. Age 35 for more, because Down syndrome is more common in those people. So abnormal prenatal testing, in those cases, we go for all of that one. Then what are the amniocentesis? How do you do it? It's basically this one. It is, if there is any abnormal screening, then we go for this one. Then they says compared to CVS, amniocentesis is way better and more accurate. So a lot of females usually go for amniocentesis, because at 10 to 12 week, usually we offer CVS, but if someone wants to go for amniocentesis, we can do amniocentesis too. On screens of the open neural tube defect, because CVS does not screen for open neural tube defect, just for your thing, because this can be asked, which diagnostic test does not screen for open neural tube defect? So chronic villus sampling does not screen for open neural tube defect. Okay. Then comes the isomerization screening. In this one, what is the main thing? So here, sensitization route. What are the sensitization route? How can RH and RH negative can be mixed up? So incompatible blood transfusion, fetal maternal transplacental hemorrhage, like any trauma or any shaking or any abruption, invasive procedure in the pregnancy, like any cerclage or anything done, any type of abortion, labor or delivery, and trauma. So anyway, where the maternal and the fetal blood got mixed up, in that cases, this sensitization happen. One of the thing here is the screening is indirect womb test, and the clear Beteke test is basically the diagnostic one or confirming the one. Then we go for the fetal hydrops fetalis, which is confirmed through ultrasound, where the all compartments of the fetus has water. So done to assess the degree of the fetal anemia, how much there is, sorry, the cerebral artery Doppler is done to check for the anemia and all that. Concentration for the fetal HB should be used caution, like not a first line. So simple, we go for the screening for with the indirect womb test, then go for clear Betke test. Simple, you just need to remember this. If they can ask for the hydrops fetalis, which is directly asked question, in that case is going for ultrasound detail checking how much is there and all of this. Then did standard dose for 300 rogam. So in any kind of pregnant female, like how we were talking about any kind of wound, you have to talk about tetanus. In any kind of pregnant female, after doing beta HCG, you have to give the rogam. Rogam is one of the most important. If they give you RH negative female, then it's more than good. If not, then at least, on the safe side, you can write down rogam. Exogenous RH program binds to RH antibody and prevents them from further spreading. So when are you going to give? At 28 week? This is very important. At which time? 28 week, within 72 hours of the birth, then with any invasive procedures. So even when you're doing a 10 to 12 week any CVS amniocentesis, you have to give the rogam. So that's why I said it's safe to give the rogam wherever you're talking about any female abruption, any bleeding or whatever the emergency is. So in that cases, you have to talk about rogam. As part of the management of ectopic pregnancy, miscarriage, antepartum hemorrhage, that's why I said any kind of bleeding in the pregnant female, always in your management, there should be Rogam. So if they say, so what is the one thing that you would like to do for this female, or what is the one management thing, and you cannot come up with anything, so Rogam is something you can just go without thinking. Rogam provides a sufficient prophylaxis. A clear Bedke test is done to find out what's going on and all that. Then biliary pigment wants no intervention. It means it's getting better. Intrauterine transfusion between 18 to 35 weeks of O negative packed cells may be required for severely affected fetus, early delivery of the fetus. So in that case, you just need to know, like in pregnant female, what kind of RBCs should be given, O negative. Then complications is anti-RG and IgG, then hydrops fetalis edema in at least 2 compartments due to the fetal heart failure, and then erythroblastosis fetalis could be there. Then comes the fetal surveillance, the non-stress test, one of the most important. So any female who comes with the distress, dehydration, vomiting, nausea, whatever it is, in that case, especially if they're coming in second trimester, like 18 weeks to a 16 week or whatever, in that cases, you have to ask about the fetal movement. Our first question about them is asking about, is she able to feel the baby movement, or if she is able to feel the baby heart rate, although it's not like a something they can do it like this, like, oh, I don't know. So in that case, you can tell them it's fine, but you have to make sure that you ask about the fetal quickening or at least the movement. Can occur in 1 to 2 week early in the multigravida, so can occur in 1 to 2 week later. If there is a concern about decreased fetal movement, the patient is counseled or choose a time when the fetus is normally active to count the movements, like when they're especially sleeping down or laying down. In that case, is ask them to lie down on one side and then count the movement. All high risk patients should be advised to do the fetal movement counts. So should experience at least more than 6 perceived movements in 2 hours. If there is a subjective decrease in fetal movement, time, how long it takes, and how was the movement and all that. If 10 movements take more than 2 hours, then further assessment is indicated. Patient should present to the labor or delivery for the assessment. So first thing, if they ask for what is the first line or what is the next management or whatever it is, in that case is for the fetal surveillance or for the fetal well-being is fetal movements. Don't go for ultrasound or whatever. Then the differential diagnosis of decreased fetal movements is DASH, then death of the fetus, amniotic fluid decrease, then sleep cycle of the fetus, or hunger or thirst. Non-stress test in that case is fetal heart rate tracing more than 20 minutes using a continuous external fetal monitors to assess the fetal heart rate. Indications in which cases we do any kind of uteroplacental insufficiency. In that cases, we go for the non-stress test checking for the fetal heart rate. So now the baseline, a simple straightforward baseline, how much it should be, 110 to 160. How much it can go up and below? So 100 to 110 or more than 160. So if this is something there, then it's fine. So usually what I remember from this table is normal reading. And if it's less than 100, it's basically bradycardia. If it's more than 160, it's basically tachycardia. Simple. I just remember this thing from here. Then comes the variability. If the normal variability is around 6 to 25. So if there is anything changing between 6 to 25, it's basically variable. Then deceleration, there shouldn't be any deceleration. When it comes to acceleration, then spontaneous acceleration, but not required acceleration with the scalp stimulation could be there. Then interrupt clinically that there is no fetal compromise. Now, when you remember the normal, anything that is happening to these values, it is abnormal. For your idea, if you keep the if you could easily remember the normal one, then just whatever is coming in the values change, then it's just abnormal. So 110 to 160, if anything happens below or change to that one, it means this is bradycardia and tachycardia. So from this table, if you could remember the normal tracing and abnormal tracing, and whatever comes in the middle is basically atypical. So 110 to 160, we already discussed this one. Variability 6 to 25. If 5